Hi everyone. I was initially quite pleased to be speaking earlier in the day, but after quite a thought-provoking keynote, let's see how I go. So I'm just going to give you a really quick, a bit more of an introduction about who I am, really quick. So it's John E. Pearce. The E stands for Evan, not Edwin or Egbert or anything like that. I use the E because there are a lot of John Pearces in the world, and I don't want to be mistaken for any of them, particularly Mr. America, though I don't think there's much chance of that. So I work at Peninsula Health. I have loads of kids. I'm a bit of a nerd. I'm starting a PhD in about a month, and I created a facial therapy website. I'll just stop there so you can write that down. Okay, so that's me in about 20 seconds. So the title of my presentation doesn't make a lot of sense until you know really what my topic is, and that is this. I guess there's still the odd person in the health world that really doesn't value what we do. You might get the odd doctor sort of dismissing everything we do in a sentence or two, patients who aren't interested in therapy for whatever reason, or even parents, in the paediatric world who just think the whole thing's a bit of a joke. But I think that's happening less and less these days, and I wonder whether sometimes our largest critics are in fact ourselves. I think that there's possibly a microculture of self-deprecation in speech pathology. We sometimes joke that there's no evidence for this, or we're just filling in time while they recover. It's like we feel if someone looks too close at the evidence behind what we do, then they'll discover that it's all a bit of fraud. I don't feel like that, but I guess I've noticed a lot of people who do sort of come across that way, and hopefully you don't either, but perhaps if you even feel like that a little bit, this presentation will help a bit. I think one of the ways to make it obvious that we are, a mature and professional discipline is to have a look at some of our therapy materials and textbooks. So I went ahead and did just that. As you can see from these sort of images, we are very mature, very professional. There's really, I don't know what the background story for that is, but the more I looked for these, honestly, they're everywhere. Why she's having so much fun pouring juice? There's got to be vodka in it. I'm not sure, I don't do paediatrics and neither do most of you. I don't know what that is teaching you to do, but I think it's illegal. There are so many of these. I wish some of these were a joke, but they're just not. That's my favourite. My daughter, I had Duffy open one day and my daughter came past and she's like, what are you reading? I can't explain that. Okay, so maybe I'm a little bit embarrassed about some of our materials and the age of some of our things. But let's talk about the evidence. So I think partly maybe it's an inferiority complex. We feel like, even looking at physio, the amount of evidence they have, the quality of the evidence they have is great. Let alone medicine. We think they're sort of perfect compared to us. I know I used to, just the amount of research they have for everything they do. But when I was in ED a couple of years ago, I overheard an intern talking to a registrar. And the registrar was talking about emergent intubation. And the intern said, don't you have to push on the cricoid that seals the esophagus and stops reflux and aspiration? And the registrar said, oh no, they've done a study on that now and it doesn't actually do anything, so we don't bother doing that. And the intern said, oh, well, why have we been doing it for so many years if it doesn't work? And this is what got to me. The registrar said, oh, there's no evidence for anything we do except medication. We just make it up and hope for the best. So I thought, even if medicine think that, maybe it's sort of something all disciplines do to some extent. So I'm going to remind us about some of the scientific principles. Hopefully it's stuff that you all know, but it's just a bit of a refresher. So number one, absence of evidence is not evidence of absence. In other words, just because there's no evidence for something doesn't mean there's evidence it doesn't work. For example, homeopathy, you take a small amount of something and you dilute it so much there's none of it left. You're giving someone water. There's evidence for absence in homeopathy. Some good studies. In other words, it has good quality studies that show no effect. And the NHMRC review in 2013 concluded that it fails to demonstrate an effective treatment for any of the reported clinical conditions in humans. Chiropractics has evidence of absence. There's good quality, a systematic review of low bias studies, so really good quality studies, show that it's no better than placebo or sham therapies. And acupuncture. At best, it shows weak effects for pain and really no better than placebo. A lot of money have gone into studies for those, and they show no effect. That is evidence of absence. Speech pathology, absence of evidence. And that's an important difference. So how many times do you come across terms like this? Now, that's still a problem, of course. That's not great, but it's not the same thing. The key difference between us and sort of non-scientific professions is that what we do is plausible. It makes sense. It's based on anatomy, physiology, learning principles, It's based on what we know so far. It's not plausible that 1/1000th of a drop of duck liver can cure a cold. It's not plausible that deviations in the spinal cord that can't even be detected can cause asthma. I've heard that claim. And it's not plausible that a needle in the skeletal muscle in your leg can affect your liver function. We simply don't have the studies yet. Number 2, studies are contradictory initially. So I'm sure you've all experienced this. A new study comes out and says we've got this new treatment, it appears to work on this group of people. And then another study comes out and says, didn't work for us, no effect. It's quite frustrating. But if you think about a coin toss, if someone gave you a coin and said, I want you to flip this 4 times, we're expecting the odds of heads to be 50%, you might say, no, it's 75%, or we didn't flip any heads. I think your method's faulty there. It actually takes well over 100 coin tosses with a 50% chance to start hitting that consistent result. In other words, a clearer picture emerges over time with more studies, with bigger sample sizes, with better quality. So it's not that there's fraud going on or that the studies you're reading are wrong. It's just that small sample sizes is where we have to start, and they contradict each other. Number 3, we need deductive top-down research. So a common complaint is that you read a research article, particularly in the journal club I'm in, and it's of no use. You can't apply it to clinical practice. It doesn't apply to the real world. So I get annoyed at these sort of titles coming up in literature searches. Comprehension of directly and indirectly stated main ideas and details in discourse by brain damaged and non-brain damaged listeners. Sounds good. Investigation of an HMM-ANN hybrid structure in pattern recognition application using septural analysis of dysarthric distorted speech signals. I don't actually know if that's speech pathology, but it said dysarthria in it, so I went with that. Some observation from the perspective of the rare cognitive comparison theory of language acquisition. So you think, great, thanks a lot. But you know what, not every article published is just for us. It's the way researchers communicate results to each other. And we need to understand the theoretical stuff before we can apply it to our practice, which is sort of our end of the stick. We need to have models of how language is produced before we can start treating it. We need to understand the complexities of conversation, which we still don't, before we can treat language at that level properly. And we need to sort of philosophize, if that's a word, about language acquisition before we can start treating children. So although it can be frustrating, some of these articles, they are important. They might not just be important to us yet. Number 4, and this is possibly the most relevant one. Communication is not medication. So much of the research system as we know it was sort of developed around medication and medication trials. And things like systematic reviews and rating scales are based on those. For example, SpeechBite, which I'm assuming everyone knows about, they use the Pedro P rating scale, which scores an article out of 10, an experimental article out of 10, based on its quality. Now, SpeechBite has almost 4,500 articles, and guess how many of those score a perfect 10? There are 3. The first one is a medication, second one is a medication, the third one is a medication. And in fact, all of the 9s are all medications as well. Why is this? Are we just really bad with our study quality? If you think about it, how do you have a placebo in communication? You know, even having someone turn up and have a conversation with you each week could potentially improve their communication. What about blinding? How do you give a patient some sort of therapy without them knowing what they're getting? They're designed for pills, you know, you take a sugar pill. Double blinding, you can blind the person assessing the results, but you can't blind a speech therapist to what they're giving a patient. And that really applies to swallowing as well. You know, unless they're almost identical treatments, you can't blind the patient or the therapist. So when you start to think that maybe the best score we can get is sort of an 8, realistically, suddenly our literature doesn't look so bad. Because communication is highly complex, it's highly nebulous, it's not just a matter of measuring, you know, blood pressure, has it gone up or down. It's very difficult to objectively score things like, you know, improvement of an autistic child, their communication day to day. How do you objectively measure that? Because maybe they're just having a good day. Or what about verbal reasoning ability in someone with TBI? Have you improved that or not? Now, certainly we have methods to do these and they are reliable, but it's just not simple, is what I'm saying. Even intelligibility itself, there's a lot of debate about how to measure that. So the things we study aren't simple. And I guess I've talked about communication. What about swallowing? That's far more sort of objective and obvious, and I think that's what draws a lot of people to it. Even our gold standard assessment of our most measurable practice is open to interpretation. If you get 5 people in a room, 5 species, you'll get different results. Hopefully the recommendations will be similar, but different interpretations. But I think that's okay, because chest auscultation, how subjective is that? It seems to change every day when the doctors are doing that. But they don't seem to beat themselves up about it, it's just a tool they use, it's not the be-all and end-all. Or radiology, I mean, sure, that can pick all the obvious things, but you will get different interpretations of the same X-ray. Or if you've ever watched a neurological exam, there's a lot of subjective sort of measurement in there, you know, pushing on one side, pushing on the other side. Just because something's not directly quantifiable doesn't mean it doesn't exist. But I hear a lot of speech pathologists saying, oh, you know, we all have different opinions and it's all impression-based, so therefore it's not really there. Not in those words, but. Number 5, evidence evolves. So how many times have you read something that says there is a need for more randomised control trial studies in this area before any conclusions can be made? I think it's easy to conclude that we don't have evidence based on these sort of premature systematic reviews. I sometimes wonder why the author's done them. It's like, there's only 2 papers. You know you're going to get 2 papers and you know that's not enough to conclude anything. So it's easy to be despondent reading systematic reviews because they're at the top of the hierarchy, aren't they? You know, evidence hierarchy. But we actually have to start at the bottom. You know, ethically it's arguably unethical to start with a randomised control trial for a lot of things. You have to have the lower evidence. Often that'll start with just a single case study and we tried this and it seemed to work, and then case series, and you have to have enough of them to show that this seems to work in the majority of studies. You have to work your way up. So it's not that we don't have any evidence, it's just that we're still moving up the chart in a lot of areas. Having said that, this is a systematic review of randomised control trials in dysphagia, and they say data supporting swallowing rehabilitation methods with adult dysphagic patients is advancing. Although studies' intervention approaches remain diverse, the use of randomised control trials is increasing with noted improvements in control methods. So they're saying it's getting better. Same study. Previous reviews have identified a publication rate of 0.36 trials per year, which has now risen to an average of 6 per year. Moreover, the use of methodological control strategies within current trials is continuing to advance. Now, it is to do with funding and things like that, but it's also just a matter of time. We are a young profession. But, you know, there's good news. Things are improving. We're getting more studies and better quality. So I'll try and conclude. This is just a great quote when you're reviewing an article, because if you're in a journal club, you tear it apart. But in the end, maybe it's not perfect, but there are things you can draw from it. Perfect is the enemy of good. So evidence-based practice demands we use the best evidence, but it doesn't demand we have perfect evidence. It's just the best available evidence. And of course, we use what our patient wants and our experience to augment that. So I'm pretty confident the evidence will arise for what we do. And even if it doesn't for a particular treatment, I think, if we show that something doesn't work, we'll stop doing it. And I think that's the difference between us and some of the non-scientific professions. So some questions to ask yourself. Is speech pathology any different from 10 years ago? And the answer is easily yes. So that shows we're advancing. Is your practice any different from 10 years ago? I've not been around that long, just for that one. So mine is. Or what about 5 years ago? You're doing things differently? What about last year? You should be individually doing something different. You should be evolving as well, your practice. It's so easy to do things a certain way because that's the way we do it. And then you come across a study that it should change, and it's so much effort to turn the ship around and do something differently. But it's our obligation, of course. So no one's going to love us if we don't love ourselves. How can we be taken seriously in the meantime? I think we need to speak positively about speech pathology. If we're going to pay out on it, it should be between ourselves, I guess. Having said that, we explain what we do know so far, but we don't have studies for whatever thus far. Explain what we do know, be honest about what we don't know yet. And I think research shouldn't be something just done by the researchers and handed down to us on a plate by the end. I think, and it's happening a lot nowadays, but we should be, as clinicians, involved in research a lot. If your place of work isn't, if you call a university and offer it, I'm sure they would be over the moon, because finding participants is more difficult from once you start working in academia. So based on all that, that's why I conclude that speech pathology is okay, really.